All right. So our group norms and guidelines for today's meeting, I will lean into difficult conversations. I will believe everyone is doing their best most of their time. I will critique ideas, not people. I will use I statements. I will accept a lack of closure. I will not make assumptions about other people's identities. I will take care of myself and take breaks if I need to. I will agree that what is shared here stays here, and what is learned here leaves here. I will call in rather than call out, but never feel obligated or required to call someone in. I understand we are all on different levels of awareness and will practice understanding with each other. I will participate in active listening with no interruptions. And please feel free to use the thumbs up reaction to show group members you've completed your thought. Our speaker for today's event is Linda Anders. There was a change in the topic of our presentation, but we're doing something that's a little bit more encompassing, which is back to the basics. And after she presents today, we will do some house, I don't know what it's called, some just checking in about future voices. So I'll let Linda go ahead and present.
Lovely. Thank you so much. I am so pleased to chat with you all today. I feel as though this is going to be more of a conversational dialogue rather than me speaking at you. So feel free to turn your camera on, to chat away. I really do want this to feel inclusive, and I love everything that you just spoke about in your group norms. I think it aligns very well with me as an individual and me as a professional. So like she said, I'm Linda. I am actually the nursing education programming manager with Sigma Theta Tau, if any of you are members of Sigma, and that's actually how I got involved coming here today. Desiree, I believe, posted on the circle like our internal communication for all Sigma members several months ago, seeking some content experts to talk about various topics. I am, as you can see, double mastered prepared. I'm board certified in nursing professional development and sedation certified RN. When I was preparing for the topic today, I really wanted to I love to talk about gender and inclusivity in healthcare, but I think it goes bigger than that because there's so many other things that are impacted or impact gender care in healthcare. So that's why I pivoted, and I apologize to the team leading this, that I pivoted to back to the basics, seeing patients as humans, because it is more than just categorizing into gender or categorizing into race. It is such a bigger conversation than that. And I felt like we would be remiss if we didn't really talk more about the other things that we're going to dive into today. So I did create a little objectives for us. So I really do hope that after today, we'll walk away with being able to identify what implicit bias is and how we can combat that in the healthcare setting, and then also to be able to describe various ways to see patients as humans. And Kimberly briefed me that most of you are undergrads, which I love it because I still remember my undergrad program. It's like burned into my brain. So I will try to ensure to get it to your level and not be too up here in the clouds. So we'll definitely bring it down. And so either during or after this time today, sometimes we sit through these things and we might be doing other things. We might be multitasking or thinking about various things. And so once we step away, we might have an opportunity to let that information sit with us and want to ask questions afterwards. So I did create a Padlet. So if you guys want to scan the QR code or and I'm pointing this way because it's on my other screen. So if you want to scan the QR code or use the link that we have here, you can add questions or comments onto that Padlet, and I will answer them afterwards. So I'll leave it open for about a week. probably until Friday the 21st, and then I'll answer all of those and then send it back to probably Desiree, and then she can disperse it to all of you so you can have the answers to the questions and the comments as a way to continue the conversation after this set time together. Let me know if you have any questions about that. The first thing I want to do is just, before we dive into some content, I want to show you some pictures, and I want you to think about what these pictures evoke in either your mind, your heart. Just take notice of, does your heartbeat quicken? Do you have any initial gut thoughts or reactions? Do you put these individuals into categories? So just, we're going to sit for a minute with these images. Are you putting these people into categories in your mind? And are your initial thoughts related to any implicit bias that you might have, or any type of bias whatsoever? So bias, really, there's so many different types of bias that we can look at. In our culture today, bias has, especially implicit bias, has such a negative connotation, but that's truly not an accurate description. So bias overall is attitudes, behaviors, or actions that are prejudiced in favor of or against one person or group compared to others. And so it can be you have a bias in favor of, like, for instance, when I worked in the ICU, I absolutely loved the little old ladies, right? Like every time I saw a little old lady from a nursing home, like my heart skipped a beat. I just absolutely loved them. So I had a favor for them, right? Whereas most of the time we think of bias as always being negative, and that's not necessarily true. But when we look at implicit bias, it is a form of just the generic bias that occurs automatically or unintentionally. Nevertheless, it affects our judgments, our decisions, and our behaviors towards one person or groups. So we might think that as healthcare workers, and I know that when I was a student nurse in my undergrad degree, I had kind of rose-colored glasses. I would see the world that, you know, all the nurses, including myself, would treat everyone the same, because one patient is a patient is a patient, but that's not really true. And when we take a deeper dive into introspection and reflection, that is going to reveal maybe something else. I did some literature review prior to this presentation, and I found a systemic review by Fitzgerald and Hertz from 2017 about implicit bias, and it showed that of the articles that they reviewed in the systemic review, almost all of the studies found that there was evidence of implicit bias among physicians and nurses in the United States healthcare system. And so what did that look like? So the systemic review found the following that you can see listed here. So physicians and nurses manifested implicit bias related to race, ethnicity, gender, socioeconomic status, age, mental illness, all of those sorts of things. So I would assume, are you guys in clinicals right now? Do you guys have clinicals? Yeah. So let's say that you're getting ready to prepare for your clinical day. Is there a type of patient that you look at and you go, oh, really didn't want that patient? Or you see the patient and you're like, oh, this is going to be a really difficult day. All of those feelings and those thoughts stem from our past lived experiences, right? And our implicit bias that we have towards that individual. So something unconsciously that is there that makes us feel that way. According to an article by Heath in 2020, In healthcare, implicit bias can shape the way medical providers interact with patients. Because everyone is susceptible to implicit bias, even clinicians, these unconscious perceptions will naturally seep into patient-provider communication and lead to different treatments for the individual. And what I really loved about that quote is the word seep. So it's not just kind of there, it's not on the surface, it's embedded into the conversations. So if you remember, we said that it could be in favor of or could be against one person or group compared to another. So when I think about this and I reflect and speak openly and honestly and transparently about me as a nurse. So I've been a nurse for 12 years. I started out on a med tele unit, then went to ICU. ICU was my jam. I absolutely loved it. And then also clinical education. I think about all of those times when I was in ICU and I think about categories. Like I would put patients into categories in my mind. Like, oh, that's just a kidney failure patient, or that's just a heart failure patient. And putting them in those boxes also had connotations that I had associated in my mind with that diagnosis or their lifestyle behaviors or et cetera, et cetera. So looking at the systemic review findings, initially it seems kind of harsh, like, oh, physicians and nurses wouldn't have any type of bias towards somebody that's a different gender, but that's not really true. And when I reflect on my own opinions and my own beliefs, I can see that very clearly, especially when I worked in the ICU setting. So we're gonna move on to what can we do, right? So we identify that these things exist, and how do we identify it within ourselves? So we always have to begin with self. And one of the hardest things I think as humans is to acknowledge that we are all self-driven, self-ego. Like our ego drives a lot of what we do, and our pride can get in the way a lot of times because as humans, we're pretty prideful people. So being able to acknowledge that we're flawed and that there are things we need to work on can be really challenging. But I do think that when we take the time to become a better human, that it's going to reward you tenfold. So when we begin with self, we need to think about reflection. Reflection would be what I would say is like the first step. So self-reflection can identify any implicit biases that we might have. And it's going to uncover some stuff in ourselves that we might not have identified before. So when I say reflection, I mean sitting with the stuff, sitting and really taking a look inside and knowing that, yes, just like your group norms say that everyone's doing their best most of the time, we can identify that we truly are doing our best most of the time, but there might be something there, right? There might be something there some of the time that we need to reflect upon. The second aspect is introspection. So this is a little bit different from reflection. Reflection is more surface level. Introspection is really getting into the meat and the bones of it, our mental and our emotional processes. So reflection is like how we feel per se, and introspection is getting into the processes. Why do we feel this way? Why are we thinking this way? Why do we have these beliefs, etc.? And so when we do that, it can be so enlightening and it can reveal things in ourselves that we've never even know that we had experienced or that we are using as a lens to see the world through. And the last one would be an assessment tool. So I am not by any means associated with Project Implicit through Harvard, but I think they have some great tools out there. Project Implicit has an implicit association test that you can take, and there are a variety of them. And I will share the link on the Padlet. Thank you, Kimberly, for adding the Padlet into the chat. I will share that link on the Padlet for you to use. You can identify, do you have ageism bias? Do you have gender bias? All of these various components that you can test out on. It is available for anybody 18 years or older. And I would say, like I said, I'm not funded by them. I don't get money from them. I'm just saying it's a really great free resource if you've never done any implicit bias assessments in the past. I think it's a good place to start. This next slide is a little bit deeper and goes into a little bit more about our personal privileges and others' health inequities. And I would say that once we've done reflection, we've done introspection, and we've used the assessment tools, we really need to start to educate ourselves while being aware of our own personal privilege and other health inequities. And this can be really challenging. And I would also say that the reflection, introspection, and assessment, there's no like designated timeline for that, because as you go through those motions, you might need to work through some stuff, right? So you might need to take some time to work through that. And so it might not be, oh, day one, I'm going to reflect, day two, I'm going to do introspection, and day three, I'm going to do a assessment tool. It might not look like that for you, and that's totally okay, because we all come from different places and spaces and see the world through different lenses. So I want you to have some patience with yourself as you're working through that. But once you get past those aspects, we also need to reflect and look at the system inequalities, the privileges that are available, and the oppressions. And this is actually on the screen, you're seeing what is called the coin model. And I'm kind of going to give a few clinical examples for this. So a lot of times in the clinical setting, it is easy for us, from our privilege standpoint, we could say the top of the coin, to say, well, if this patient would just eat better and they didn't eat crappy food, then they wouldn't have heart failure exacerbations and they wouldn't be readmitted. Okay, that's simple to say, right? But we're truly seeing that patient through our privilege lens. So we might have the funding to buy whatever food we want. We might have the funding to go to a grocery store that has healthy, fresh foods, etc. But we don't know where this patient's coming from, right? So if we looked at that patient, do they live in a food desert, something they can't control? Are they low income? Are they disabled? What are these different variables that are oppressing them that we cannot see? So once again, this coin model is from Stephanie Nixon, and I did get permission to use it. She is fully willing for people to disseminate this model. You can see the article from her in my references when we get to the end. And I would highly recommend you take some time to read the whole article, not just focus on the visual diagram, but I'm a visual person, so I'd love to see the diagram. It definitely helps make it click in my brain. So if we look at our heart failure patient, okay, so we're frustrated that they're coming in again because they're being readmitted. They didn't follow their diet. It's a waste of our healthcare resources and money. Now that is true, right? Like all of those are true, but what's also true is the fact that our heart failure patient does live in a food desert. So within a mile, they have no access to fresh food. What's also true is that they live in a low income housing unit. What's also true is they don't have transportation that's reliable. And what's also true is that they are disabled and cannot work. So when we look at the bottom of the coin, that's the oppression, right? So things that are of disadvantage to them that they did not earn. And then whereas we're up here in our little privileged state, in a privileged state with advantage that others do not have and we did not earn, because I was not born in a low income housing complex. I was not born into an area that has a food desert, right? So these are some things to think about. That's a pretty cookie cutter example. Like, I feel like everybody uses the heart failure patient for every example for everything. So I want to take it a little bit to a different side of it, and let's talk about let's say a male relationship, a male dating a male, or a female dating a female, somebody that may not be traditionally accepted in society. So if we look at it from that lens, we can see that people who are straight enjoy the privilege or the advantage from the social structure of being heterosexual, and that's our dominant norm in most societies. It's still our dominant norm in the United States. So these individuals who are heterosexual, they are experiencing a life where they can freely express their affections for their significant other without fear or discrimination, right? So let's say if I were dating a male, we go into Target, we're holding hands, we do that freely and it is accepted, and we don't fear that because we're holding hands, we're going to be discriminated against in Target. So if we think about it in that regard, it could be seen that straight people do not choose to be straight. They just are receiving this privilege many times without even knowing it. So we don't think, oh, I'm going to hold my significant other's hand while we go in the Target, and this is such a privilege. I'm so grateful, right? We just do it because we want to show affection to our significant other. But people who are not straight do not enjoy that freedom that we just described for straight people, and they do not experience a sense of inclusive or belonging from the social structure. Those who identify as gay, lesbian, bisexual, pansexual, and the list goes on, do not align with the dominant norm, and they have received unearned disadvantage. And you can see that on the coin model. So on the top of the coin is the privilege. The coin itself is system inequalities, and the bottom of the coin is the oppression. We could literally spend, I would say, hours on just the topic of system inequalities, which I'm sure we're all very aware of. And that is a completely different, deeper conversation that we could have. And as you know, it has many facets. So this is still from Stephanie Nixon's article about the coin model. And this is just a deeper dive into the system of inequality. And these occur all of the time. We can see these interwoven in our day-to-day work, all of the different systems of inequality. And I actually, to share a personal story, this actually happened to me yesterday. So I have a cut on my cornea on my left eye, and I went to urgent care, got medicine. Well, it's not going away. So they told me to follow up with my local eye surgeon associate, see what they needed to do, see if I needed surgery, etc. So I made the appointment, filled out all of this stuff on the patient portal, and checked, of course, because insurance dictates everything that we do. So check to make sure they accepted my insurance. I go on my merry way, get off work early yesterday to go to this appointment. I'm standing there checking in, they're asking me all these questions, and they look at my insurance card and said, well, we don't accept this insurance. And I was frustrated, and I am a redhead. I don't know if you can tell. So sometimes my temper can get the best of me. And I said, well, that doesn't make sense, because on my insurance app, it said that you guys were in network and accepted it. Your patient portal said it accepted it, blah, blah, blah. So they would only cover if it were coded 100% a medical visit. So my eye, like my eye screening wouldn't be covered, glasses wouldn't be covered. The only thing that would be covered would be the provider looking at the scratch on my eye and prescribing whatever treatment plan they felt was appropriate. And so I just said, at that point I was frustrated. I said, okay, I'll go down the road to your competitor who allegedly accepts my insurance. I'll just make an appointment with them. And when I got out to my car, I actually started to cry, not for my own reasons, not because there's a cut on my eye and I could go blind, none of those things, but rather I cried thinking about me as a cisgender white woman, like privileged. If I have this problem, I was thinking about all of the patients that have such significant barriers just to receive care. So if I didn't know that there was an organization right down the road that provided the same care that this facility that rejected me did, then I would just sit in a space of, okay, well, this is my fate. There's nothing else for me to do. If I didn't have transportation to drive there, if I didn't have the wherewithal or the ability to check the app, all of those things, it truly, and this is me being 100% transparent with you, truly brought me to tears thinking about, this is why I went into healthcare, because these things should not happen. If somebody has a cut on their eyeball, we need somebody to take care of it, right? Because if I lose my vision, I lose my career, I lose everything that I've worked hard for. So if this is happening to me, it's happening 1,000-fold everywhere else. So we need to fix these systems of inequality. We need to be able to identify our privilege and other people's oppressions and to move the work forward. And so that's why I really took this presentation and pivoted it, because I just felt like it's a bigger conversation. Gender conversations are so important, and I've done a lot of work in that space with ANPD and other things, but it's so much bigger. So I hope you guys get where I'm going with that. So like I said, this is kind of heavy. I would recommend reading the article by Stephanie Nixon. So what do we do then to see our patients as humans, to take a step back and to say, okay, this is a person in this bed, or if you're just practicing in the sim lab, like essentially this is a person in the bed. So how can we transition our thought processes to treat that person with dignity and respect? And I feel like as nurses, we are called to take a step up and acknowledge where we come from and be honest with ourselves and our thoughts and our feelings, so that we can treat our patients as humans. So we can treat our patients as the best way possible. So just a couple tips I created here, just a little checklist. I would say that as nurses, especially nurses today, it is really hard to think outside of the checklist. Like, how am I going to get all of this done? How am I going to pass all of the meds, make sure all of the baths got done, AccuChecks, vitals, all of that stuff? How am I going to do all of that stuff and not look at the patient like something to check off of a list? So these are just a few things, and they will come in time, I would say, but just being intentional is one of the most important things. But do not assume. I mean, this is pretty straightforward, and we've heard this forever. But I would ask that we all have an open mind and care, and we're caring for all. And one thing to consider here is do not assume gender. So I would say a polite thing to do, especially I know Desiree's from Missouri, like Midwestern people, especially we say things like ma'am and sir. And I know that's out of respect, but I do think that we need to sunset those type of languages and phrases because they may not be appropriate any longer. So I would say, let's go ahead and sunset those and use more gender neutral pronouns. Our patients deserve to be seen more than just part of a category of a ma'am or a sir. The second one is being intentional with your words. This is really important to take into consideration how we speak. So a lot of times we are quick to speak and slow to listen. And so I would say, let's reverse that and make sure that we are being very intentional with our words. For instance, to see our patients as humans, we can ask their pronouns. We can ask them what name they prefer to go by and how they would want to be addressed. Being intentional makes you take time to notice how you are feeling, and then also gives them time to speak to us and share what they want us to feel, right? Use gender inclusive language. So start to utilize appropriate pronouns when you introduce yourself. So in the clinical setting, I say, hi, my name is Linda. My pronouns are she, her, and hers. And that really does, it's just a gate that you open, allowing these patients that if they feel comfortable, they can share their pronouns also. I think a way to foster a safe space for this is really just asking directly, like, what pronouns do you use? Or I want to make sure I get your pronouns correct. What are they? You can be as blatant as that, and that's okay. And if they say, I don't want to share, you can respect that and say, thank you for answering. I respect your decision. That's no problem. The next one is apologize. This goes back to our pride and our ego. So we do not like to apologize a lot of the times, especially when we make a mistake. But we know mistakes are going to happen. I would say just apologize and correct the mistake. There's no need to like ruminate on it and to really sit with it for a long time. Just be intentional and say, thank you for correcting me. And then also acknowledge that you don't plan to do it again. Because when you acknowledge that you're not going to do it again, or you're going to make efforts not to do it again, you're showing that vulnerability aspect with your patients, and you're allowing them to develop rapport with you. Like, okay, this person, they're solid. They're a good human. They apologized. We can move on, and that's that. And the last one is educate yourself. And this is one thing that I absolutely love about the group that's here tonight. You are working on that, right? So you're coming to the table, you're educating yourself on a lot of different things. I applaud you for that, especially in nursing school, because to do one more thing is so daunting at times. So I would say always continue to educate yourself, read articles, read books. There's a lot of different things out there that you can do to educate yourself, webinars, events, all of that good stuff. And then I would say, truly, and this is kind of cheesy, but as we end the formal content of this conversation, I just want to bring it back to we're all in this together. Each one of us has a part to play. We have a piece of the puzzle. So I would ask that we set aside our preconceived notions, thoughts, work through our biases, and really look at our patients and each other as humans. So I did provide my references here, and if you want the slides, I'm not sure if I can upload the slides to Padlet, but if I can do that for you. And then of course I do have my digital business card. You can scan this. This will give you my direct email address if you want to connect afterwards, and then my LinkedIn professional account. Oh, okay, perfect. Yeah, you can share away. Totally fine. So that's all I have for you. I hope it's been helpful. I don't know, do we open it up, or do you want to do your housekeeping things, or?
No, we typically just open it up for a bit afterwards. I actually wanted to share a personal story. When one of the slides you talked about not making assumptions, and I made a very embarrassing mistake one time of assuming somebody's visitor was their daughter, and it was in fact their wife. And it was super embarrassing, and I apologize a million times, but I've never made assumptions about who's in the room again because I just like wanted to never speak to that patient again. But of course, I had to care for them all day.
Yeah.
So I learned my lesson that day.
Yeah, I love that. And thank you for your honesty and transparency sharing that. I had a very similar situation. I had been a nurse for about a year, like almost exact situation. But I don't know why I didn't think of this. It was our hospital priest, because I was working at a Catholic hospital, and I asked him if it was his wife, and it was his mom, because he's a priest. Of course, he's not married. And then I had to work with him every day thereafter. So that definitely is one of those times where I should have taken a step back, thought before I said, but it's also those moments that we learn from, right? So you learned that you're not going to do that again. So a better way to address the situation is, hi, I'm Kimberly. I'm going to be your nurse today. Who's in the room with you today? So that you don't have those awkward situations of, oh my gosh, I just said something so embarrassing.
Yeah, it was terrible. I also wanted to ask what do you have any book recommendations for us?
Books, yeah, to casually read or to like academically read.
I think like casual education.
So one book that I absolutely love is called Becoming Nicole. And this book